We continue with the benign tumor of the uterus, and we'll deal with the part 2 of it. And as we have done the clinical presentation, we have done the investigations needed, the possible complications that could occur obstetrically. So we continue on the others, the possible gynecological complications on the fibroids itself and how to manage the fibroids. The possible complications in a fibroids. One is red degeneration, haline degeneration, cystic degeneration, and calcification. These are the possible complications that could occur in the fibroid. And as we have mentioned, the malignant changes are minimal. The red degeneration, it is due to acute disruption of the blood supply to the fibroids occurring during pregnancy, after delivery, after a miscarriage. And as we have mentioned in the previous part of the talk, or in the first part of the talk, if there is disruption to the blood supply, then a continuum of complications occurs. One of the complications is red degeneration, and it occurs after these conditions: normal during pregnancy, or after delivery, or after a miscarriage. It presents with acute pain and tenderness over a localized area in the abdomen or in the uterus. That's red degeneration. High temperature, leukocytosis, a picture similar to acute abdomen. So with pregnancy or after delivery or after miscarriage, red degeneration of the fibroids could present as a complication similar to acute abdomen, with pain, high temperature, and leukocytosis. If it happens, what shall we do? The treatment is conservative. Observe, give painkillers. Symptoms usually resolve over a few days. No surgery here at all. No surgical intervention. Treatment of red degeneration, if it occurs, quite serious, but yet the treatment is conservative. Observation, relieve the pain, painkillers, reduce the temperature, and usually within few days, the symptoms will improve. No surgical intervention at all. The second or the other complications in a fibroid is haline degeneration. The fibroid gradually outgrows its blood supply and progresses to central necrosis, leading to softening and liquefaction of the fibroid. So the tumor grows, outgrows its blood supply, then there is a leading that leads to central necrosis, and this leads to softening and liquefaction of the fibroids. This other group that could develop from haline degeneration to cystic degeneration, asymptomatic central necrosis, leaving cystic spaces at the center. It's just a continuum of development of complication: haline degeneration, cystic degeneration, or calcification. Degenerative changes can initiate calcium deposition, leading to calcification, detected on X-ray incidentally in postmenopausal women. So you will do an ultrasound in a postmenopausal women or during the reproductive life. In a fibroid, and incidentally, you may say this is a calcification of the fibroid as a complication. As we have mentioned in the beginning, malignant change is very rare, 0.5%. Sarcomatous usually, or leiomyosarcoma usually arise de novo, not as a complication of a fibroids. Malignant changes, mild here. Current opinion that sarcoma develops in presence of fibroid, it is coincidental, and malignant transformation is unlikely. Malignancy is probably due to a separate pathway of chromosomal deletion. So treatment of fibroids. We said the problem with the investigations needed. We said the possible complications in the fibroid. We mentioned in the first part of the talk the complications of obstetric. So the treatment of fibroids. No treatment, medical treatment, surgical treatment, uterine artery embolization, magnetic resonance imaging guided focused ultrasound surgery, and we'll see what that means. These are the common pathways of management. Then radiofrequency ablation technology. No treatment, medical, surgical, uterine artery embolization. These are the commonly one used now. Magnetic resonance imaging guided focus ultrasound surgery or radiofrequency ablation technology are now being tried and used. So what sort of medical treatment will you give? Non-hormonal medical therapy for controlling the symptoms of heavy menstrual bleeding or pain. This is not hormonal medical therapy. Includes tranexamic acid, mefenamic acid, and non-steroidal anti-inflammatory drugs. So these control the symptoms of the heavy menstrual bleeding. These are less effective if the fibroid is larger than 3 centimeters. This is the non-hormonal medical therapy, controlling the symptoms of the heavy menstrual bleeding. Then we come to the hormonal therapy. Includes combined oral contraceptive pill, levonorgestrel intrauterine system, or the Mirena, and gonadotropin releasing agonists, GnRH agonists. Agonist means similar to. We say usually gonadotropin releasing hormone analogs. The analogs could be agonists or antagonists. What we are using here is the agonist one. Or selective progesterone receptor modulators. Drug being in trial now is ulipristal acetate under investigation. Restricted use as the drug induces liver impairment. Drug-induced liver impairment has been reported. So hormonal, non-hormonal, tranexamic acid, mefenamic acid, non-steroidal anti-inflammatory drugs. Hormonal includes the pill, the Mirena, the gonadotropin agonists. Then the third category is selective progesterone receptor modulators, ulipristal. These are the medical treatment for fibroids. The GnRH, as we have mentioned, just to elaborate on it, shrinks the size of the fibroid by ovarian suppression. It acts on the ovary, it acts on the pituitary, producing more FSH, acting on the ovary, and eventually leading to ovarian suppression. Less estrogen being produced, and we know that the fibroids are estrogen dependent. So that will lead to shrinkage in the size of the tumor. That also could induce menopausal state by shutting down the ovarian estradiol production. The effects are usually transient of the GnRH agonists. Within 6 months after withdrawal of therapy, the fibroid return to their normal pre-treatment size. So a lady may take them, reduces the symptoms, reduces the bleeding, but unfortunately, once she stops the GnRH agonist, the size of the tumor will become back to normal. And we believe that longer than 6 months of GnRH agonist therapy in young patients is not desirable because there is a possibility of a bone loss, that's to say, leading into the menopause. The GnRH could be used pre-surgical therapy within 3 to 6 months course of GnRH agonists, reduces the tumor size, as we have said in the first bullet, reduces the blood loss during surgery, reduces the need for transfusion during surgery, and can make minimal invasive approach possible. We may reduce the size of the tumor, and we do it by minimally invasive techniques, laparoscopy. In case of myomectomy, after treatment, the tissue planes become less easily detectable. And this is a complication of the GnRH. When doing a myomectomy on a lady who had GnRH agonist priorly, you might find difficulty in separating the tissue planes in the fibroids during myomectomy. Medical treatment, we said, combination of estrogen and progesterone, here is the pill, may control bleeding symptoms while preventing fibroid growth. The Mirena demonstrate good control of heavy menstrual bleeding with little or no change in the size of the fibroids. The size is there, it reduces or controls the heavy menstrual bleeding. Aromatase inhibitors have been shown to reduce the volume of the fibroids without leading to the side effects caused by systemic hormonal therapy. Mifepristone and antiprogesterone shrinks fibroid at a low dose, but not available or not licensed for the use in this condition, mifepristone. We use it in other parts of our gynecology. Excuse me. So, as we said, GnRH agonist, the pill, the Mirena, aromatase inhibitors, all these are medical treatment for the fibroids. We go to the surgical treatment. Depending on the symptoms, the age of the patient, the family size, and the desire for further reproductive functions. These are the parameters which affect the surgical management of the fibroids and tell which one shall we go in for. One of them is myomectomy, hysterectomy, laparoscopically, hysteroscopically, or abdominal. So surgical treatment, depending on the age, family size, desire for further reproductive functions, and the surgery could be myomectomy or hysterectomy, and the hysterectomy could be done by minimally invasive surgery, laparoscopy, hysteroscopy, or through laparotomy. This is the surgical routes we are going to use for the surgical treatment of fibroids. Myomectomy, when shall we do it? Desire for further pregnancies, future childbearing. So leave the ovary, take the fibroids out. Subserosal, or intramural fibroids may be resected abdominally or laparoscopically. Subserosal or intramural fibroids. Submucosal myomectomy can be performed hysteroscopically. So you can do the minimal invasive surgery either through laparoscope for intramural or subserosal fibroids, or we can do it through the hysteroscope for submucous fibroids. Minimally invasive techniques are preferred whenever appropriate. Complications following myomectomy include substantial blood loss, eyeless, pain, post-operative fever. Obviously, the more invasive procedure we use, the more possible are these complications. Minimal invasive techniques, whether laparoscopy or hysteroscopy, associated with less complications. When we are doing myomectomy, we have to be aware there is a possibility of post-operative adhesive disease. It may follow abdominal myomectomy. The other point, you have to tell the patient that the fibroids may recur. Also, there may be heavy bleeding during the surgery, which you won't be able to control, and thus you have to get a consent for a possible hysterectomy. Patients wishing to conceive after myomectomy, a delay of 3 to 6 months after surgery is advised before attempting pregnancy. The most common obstetric complication following myomectomy includes uterine rupture, abnormal placentation, and preterm delivery. If you are doing a myomectomy, and then these are the possible complications, post-operative adhesions. And here the importance is that doing an abdominal myomectomy may result in adhesions that may result in tubal blockage and may result in infertility, tubal factor. So you have to be very cautious about that. You have to tell the patient if you are doing it for infertility that though it may improve the chances of getting pregnant, yet she may have some complications of adhesions. And you tell them that the fibroids may recur, does not depend on the surgical skill of the surgeon. It is just the pathogenesis of the fibroids. Heavy bleeding during surgery may occur and you may need to do a hysterectomy. Then if they want to conceive, they take a gap of 3 to 6 months. If they conceive, these are the possible complications: uterine rupture, abnormal placentation, and preterm delivery. Preferred delivery method after myomectomy with extensive uterine reconstruction is cesarean delivery in general. Hysterectomy, when shall we resort to it? The lady has completed her family over the age of 45. The hysterectomy leads to guaranteed cure of all the symptoms of the fibroids. The hysterectomy could be performed abdominally, vaginally through the hysteroscope, laparoscopy through the laparoscope, with or without robotic assistant. Minimally invasive approaches should be used whenever possible. That's to say, the hysteroscopy and the laparoscopy, whenever feasible, are preferred to the abdominal hysterectomy. GnRH analogs can be used to reduce the size and vascularity before myomectomy or hysterectomy about 2 months before. The fourth group of how we can manage, we said no treatment, medical treatment, surgical treatment, and we have gone through all of them in detail. The fourth group here is the uterine artery embolization. And here we make a small incision in the groin under local anesthesia, and under radiological guidance, a cannula is placed in the femoral artery and guided into the uterine artery. So the aim at the end is to reach the uterine artery. Once you reach the uterine artery, it is catheterized, and then you put polyvinyl alcohol powder or gelatin sponge is used as an embolic material to block the blood supply of the uterus, and thus leading to reduction in the size of the uterus. Decreases the blood supply to the uterus and ultimately causes ischemic necrosis of the fibroid. This is uterine artery embolization. The benefits include short operating and recovery time, use of local anesthesia, minimal blood loss. The outcomes include reduction in the uterine size and decreased menstrual bleeding with high rates of patient satisfaction of the treatment. Rate of reoperation is high. That's to say, you may not end or get full embolization, and then you have to repeat the procedure. Reoperation rate is age dependent, with higher likelihood of success in women older than the age of 40 years. The effect of uterine artery embolization on pregnancy remain understudied. But the American College of Obstetricians and Gynecologists advises that it be used with caution in women desiring future pregnancies. sometimes or very few pregnancies have been reported after the uterine artery embolization. So if a lady desires to have more pregnancies, uterine artery embolization may not be the best choice for the treatment. Complications include post-embolization syndrome. The lady will come presenting with fever, nausea, vomiting, severe abdominal pain. This is what they call post-embolization syndrome. Another complication of the uterine artery embolization is infection, fibroid expulsion, and premature ovarian failure secondary to compromise of the ovarian circulation. Women who would like to retain fertility should be counseled about it. Albeit some pregnancies have been reported following uterine artery embolization. So this is the complications: post-embolization syndrome, infection, fibroid expulsion, premature ovarian failure, and the effect on the pregnancy. The other group of treatment, as we said, the top four, the one we have mentioned, no treatment, surgical and medical, and then uterine artery embolization, commonly used. MRI guided focused ultrasound surgery means fibroid tissue is heated and destroyed using targeted ultrasonic energy passing through the anterior abdominal wall. The procedure is performed with MRI thermal mapping and conducted over several outpatient visits. So treatment, heating the fibroid, destroying it using the ultrasound guided by the MRI. Then we focus on the tumor, leading to its destruction as an outpatient procedure repeated several times. Procedure is not appropriate for pedunculated myomas or those adjacent to the bowel or the bladder. Potential side effects include skin or nerve pain. This is MRI guided focused ultrasound surgery. The other group, other surgical procedure, radio frequency ablation technology, currently under investigation for outpatient minimally invasive fibroid ablation therapy. Simple, outpatient, but is still under investigations. Still, we have to learn more about it, but it could be used. Radio frequency ablation, transcervical and laparoscopic ultrasound guided radio frequency ablation approaches have shown safety and efficacy in clinical trials. So still we are doing the clinical trials of it, but it could be used transcervical, laparoscopically, ultrasound guided radio frequency ablation. So we come here to the fibroids, the treatment of the fibroids. We have mentioned complications of the fibroids, either on the fibroids itself or complications during pregnancy, the presentations of the fibroids, which is the common tumor in the female, second most common tumor. So we go rarely to the other tumors of the uterus. Asherman syndrome is not a tumor, it is a complication. Most common outflow tract obstruction, resulting in secondary amenorrhea. Outflow tract obstruction causing secondary amenorrhea in about 70% prevalence. It is due to aggressive curettage, causing destruction of the basal layer of the endometrium, and thus normal regeneration of the endocrine is of the endometrium is not allowed. Aggressive curettage causing destruction of the basal layer, because in the curettage, we take the superficial layer or the medial part of it. But if you take the basal layer, which is normally regrow for the second cycle to occur, that may lead to Asherman syndrome, whereby an endometrial cavity following incomplete miscarriage or postpartum hemorrhage retain products. In this situation, the uterus is soft and myometrium could be extravagated till the basal layer. If you do extensive curettage following postpartum hemorrhage or following miscarriage, postpartum hemorrhage due to retained products, then the uterus will be friable, soft, myometrium could be affected, the endometrium could be removed till the level of the basal layer or destroying the basal layer itself. The endometrium cavity undergoes fibrosis and adhesions. This is the pathogenesis of the Asherman syndrome and thus resulting in secondary amenorrhea, the one we mentioned here, secondary amenorrhea. So the cavity undergoes fibrosis and adhesions. This is the pathology of the Asherman syndrome. Diagnosis can be confirmed by hysterosalpingography, sonohysterography, or hysteroscopy. The treatment prevention, and be very careful when doing curettage in the situation that are probably prone to develop the Asherman syndrome. So prevention of the uterine scarring by adopting expectant medical or less traumatic surgical approaches to manage retained product conception and preventing endometritis to occur. Treatment, as we have said, prevention, and then the curative treatment is hysteroscopic lysis to manually break down the intrauterine adhesions, adhesolysis, with or without Foley's catheter or IUCD. You do the lysis, you do adhesolysis, you break the adhesions, you may put a Foley's catheter for some time, or you may put an intrauterine contraceptive device for some times, or you may not do that. These are the options there for it. So here we conclude on the talk of the uterine tumors, the fibroids, the polyps, the Asherman syndrome. All these are benign conditions. So we stop here and thank you very much.